A very good morning. We're glad you're still with us here on Morning at NTV. The time now to take note on the community health insurance, tackling the National Health Insurance Scheme. I'll be introducing my guest very shortly, but in our preamble, according to the 2016 World Bank data, 3% of countries' populations have been pushed below the $3.6 poverty line by heavy out-of-the-pocket health expenditure. The recent withdrawal of US aid has also exacerbated this problem, pitting many people across the continent and Uganda in particular into deeper financial crisis. However, direction is being put towards the National Health Insurance Scheme as a substitute that will fill the void left by the freezes on aid and any other challenges that the system might encounter. The NHIS could, in simpler terms, be undesired as a system of health insurance, but ensures the population against the high costs of health care. With me in the studio is the Executive Director at Save for Health, Frederick Mukaire. Mr. Frederick Mukaire, many thanks for joining us this morning on Morning at NTV.
My pleasure. Good morning, and good morning to our listeners and all people watching NTV.
Great. First, bring us up to speed with community health insurance as a concept before we can tackle the National Health Insurance Scheme and what it means for the country.
Thank you very much. Community health insurance is a system where members of the community pool funds together to help them access healthcare services, to protect them from high costs of healthcare, and actually to make it easy for them basically to access services. So it is a pooling mechanism where every member of the community contributes some money, put it together in a pool, and then that money which is pooled helps them to access healthcare services when they need them, but also protects them from expensive services, catastrophic health expenditure. Yeah.
So this community health insurance concept works well within the spaces of the private sector, or it's something that works under the umbrella of government?
No, they are mainly in the private sector. They are mainly in the private sector because they do contribute resources, and then they are regulated under the private arrangement.
Private arrangement, yeah.
Because currently, as you know, government under the public sector, the services are free because we have a free healthcare policy.
Yeah.
So they are mainly private. And there are two types. We have the private commercial, these ones like Jubilee, Prudential, those ones. And then we have the community-based insurances, which are not for profit. They are voluntary, they are mainly operating in the community, mainly targeting low-income families. Yeah.
Are there any particular challenges that these community-based schemes or arrangements do face that could be quickly realigned in order not to require drastic change to how things are operating right now?
A lot of challenges they do face. One of the biggest challenges they face, they are not well regulated.
They're not well regulated, yeah.
And that's why we are calling upon Ministry of Health to actually provide guidelines to help them streamline their operations, because there are many spread across the country, but they have fragmented pools. Their operations are not standardized and they are still small. So they need some kind of regulation to help them standardize operations, get a coordinating mechanism, and also now get trust of the community, the public. Then we can see a big more people enrolling into them, which are the biggest challenges right now they face.
Okay.
Yeah.
Talking about coexistence, this community-based insurance model coexisting with a national health insurance scheme is something that I believe is possible, because in many countries in the West, these insurance schemes coexist alongside each other. But before you talk about the coexistence and how that can roll out, take us through the national health insurance scheme and how it superintends over these other models that might be already existing.
Well, yeah, it's good you had the PS here. Probably should have also been the right person to answer that question. But the National Health Insurance Scheme is a system which government is trying to set up so that we all as Ugandans, as citizens, move away from paying for health care out of pocket into using health insurance for all Ugandans, so that we do away with payments out of pocket each time we fall sick.
That is right.
Into now using medical insurance cards. This is going to be a compulsory scheme covering every Ugandans, into which we make contributions regularly, probably annual contributions. So every Ugandan will be required to make a contribution, and then we have a national health insurance pool where now money keeps coming to clear medical bills when any Ugandan gets some illness. So this is how the national insurance scheme is planned to work. Unfortunately, as we know, it has been discussed now for over 20 years. However, it is still under the shelf, not yet passed. A few years ago, Parliament passed it. It went to the President. He never assented to it, and it was pushed back to the Ministry of Health. Up to today, it has never been retabled. So it is something good that we need, but unfortunately it's not getting the attention that we badly need.
Where is the point of contention with regard to the slow or gradual process that its rollout or adaptation, for example, is taking?
Well, I think what I can say, first of all, when the President never assented to that bill, after Parliament passing it, he never, and at least we have not seen in the public, any reasons written
as to why he didn't
assent to it. So we can just speculate. But what we know is that previously we have been hearing that, one, he was very concerned about how the entire population, especially the poor, would afford contributions into the scheme. So there was an issue of contributions. Will the poor especially afford contributions? Secondly, there was also issues around the cost of doing business, because the most employers and the business people were concerned that they were already contributing NSSF, they are paying pay as you earn, and many of these things. So they were worried that probably this is another burden that is going to be put on the employer. So that was not very clear to the President probably and the other people concerned. Then we were also getting a lot of issues from people in the formal sector, the workers, former employees, who were not sure of who was going to contribute for the poor and the indigents. So these are the issues that needed to be clarified, and I think that's probably one of the reasons why there has been a delay. But I think what we can say right now is that now that the US aid funding aid has been cut off, probably it's time to retable and discuss the issue, because as you know, most of the budget, part of the biggest budget of Ministry of Health is funded by donors and the users out of pocket. So I think if we want to help Ugandans, the best way now forward is actually to bring back the bill. We discuss it so that at least we reduce the burden, get more funding into the health system, and make sure that services are offered to Ugandans. If I can draw your attention back to 2001, when healthcare insurance and the National Health Insurance Scheme was a major issue in the campaigns. It actually led to the President to make a major promise to do away with the then user fees policy that the Ministry of Health and Government were undertaking in the provision of a service, to what turned out to be an open air sort of infrastructure. And I'm sure it is one of the aspects that we see ourselves in this scenario where 20 years we are still debating the National Health Insurance Scheme. Now that aid freezes have conditioned a new set of realities, it's going to have to take technocrats, public health experts, a whole new round of thinking in order to arrive at the need to roll out the health insurance scheme. Do you think, since he rejected user fees after some time, he would again be adaptive to that thinking? Well, that is where actually we keep saying probably we have a policy dilemma, and he has to be convinced because some of us who are always in the community, this free healthcare policy is still very popular. And you know, the President, once the policy is popular, he will hesitate to repeat it.
That's right.
But I think he also realizes, in reality he has been talking about it in public, that the quality of services is declining.
It's declining, yeah.
We have also data that shows that the out-of-pocket spending for Ugandans is also growing. In fact, right now, it's about 40% of healthcare funded directly by people, which is an unfortunate scenario, because we are in a context of free healthcare. Usually, the cost on individuals should be going down. But instead, it's rising. So I think it shouldn't be a very difficult issue now to change.
Especially if you take the politics out of it. And also now the realities on the ground, the fact that aid has been cut. These are realities, and we have to deal with them. Yeah. What is the scenario, and this is the final question as we enter the final bit of this particular interview, what's the scenario like in Kenya or other countries within the region that we can quickly compare and say this is how we can move by benchmarking, for example?
First, those people were very swift in making the decision. And I think that's what Uganda is lacking. For 20 years, we have failed to make a decision on whether we need an insurance scheme or not. That is the first thing. Secondly, there have been deliberate efforts to implement the national insurance scheme in a phased approach. They have started with community insurance like Rwanda, and then later on supported these schemes to scale up, grow, and then merge them into a national insurance scheme. So what Uganda needs to do is to support the community insurance schemes, support the private insurance schemes, and then at a later stage we can merge them into a national insurance scheme. Lastly, there is need to regulate what we have, the CBHIs. They have been here since 1996. They have not been regulated. I think they can play a very big role. Rwanda, its national insurance scheme rode on these community insurance schemes. So Uganda can do the same because we have them. Right now, they are over 20 in number, spread out into about 20 districts, covering almost about 200,000 people. So this is a very good starting point.
Okay. Mr. Frederick Mukaire, Executive Director at Save for Health, many thanks for the perspective on community health insurance, but most importantly, your guidance on how best the National Health Insurance Scheme can be adopted and finally passed by Parliament. That will do it for our Tech Note, but now let's go to Stephen Mbide